Hi everyone, in today's video we're going to take a little break and review how to interpret an arterial blood gas. We're going to look at the different components of the arterial blood gas. We're going to talk about what those components actually are. Then at the end we're going to use my 100% non-patented or copywritten method to systematically go through those numbers so we can accurately interpret the ABG and use that to better treat our patient. Okay, so first, what are the components we're looking at on our arterial blood gas? Well, we're going to look at the pH, the PCO₂, the bicarb, and the PO₂. Now, I want to start with the PO₂ because we don't use that to interpret acid-base status on an ABG. However, it is important, so let's review it. Okay, first, the PO₂. What does it stand for? The partial pressure of oxygen in the arterial bloodstream. Little a, arterial. So what the PO₂ speaks to is how well the body is able to take up oxygen. A normal PO₂ level on a blood gas is between 80 and 100. What's interesting is that the PO₂ on a blood gas should be about 5 times the FiO₂, or the fraction of inspired oxygen the patient is receiving. So let's take room air for example. Room air is 21%. 20, 40, 60, 80, 100, groovy.
Groovy, baby.
So a normal PO₂ on room air should be about 80 to 100. If you're administering 100% oxygen to your patient, your predicted PO₂, 1, 2, 3, 4, 5, should be about 500. If you're giving 100% oxygen to the patient, but your PO₂ on the blood gas is only 200, something ain't stirring in the Kool-Aid.
Vicky, can I help you with that Kool-Aid?
This patient is not able to take up that oxygen, and that's important. Now, as it pertains to ACLS, what we've discovered is oxygen toxicity, free radicals, all of these are bad during ROSC. One study suggests that a PO₂ greater than 350 after ROSC was associated with poor outcomes. What does that mean for us? Once we get a pulse and circulation back, we got to start throttling back that FiO₂. We have to reduce the amount of oxygen we're giving to that patient to achieve a normal PO₂ on a blood gas. Now, what we're going to learn later on is that the more of something you have, the greater the numeric value, except in the pH. The more hydrogen you have, the pH number actually drops. And this can trip you up when you're interpreting an ABG. You have to remember that. So here's how I remember it. True story. I'm watching the original Batman movie with my wife, right? And at one part in the movie, the Joker falls into this vat of acid. And it dawned on me, the Joker's the big kahuna, pH is big kahuna, you can only fall into a vat of acid. That's how I'm gonna remember it. And I turned to my wife and I said, honey, think about it. The Joker's the big kahuna, the pH is the big kahuna, you can only fall into a vat of acid. You can't fall up into a vat of acid, you can only fall down. That's how I'm gonna remember it. And my wife turned to me and she said, shut up, nobody cares, watch the movie. And I'm like, okay, but through the rest of the movie, I was just thinking about this formula. I had to go back and rewatch the movie. Actually, at the end of this lecture, go watch the original Batman. You'll never forget that when the pH drops, you become acidotic. Next, let's talk about the PCO₂. What does it stand for? PCO₂ stands for the partial pressure of CO2 in the arterial bloodstream. But what is it? For the purposes of ABG interpretation, the PCO₂ is a respiratory acid. That's what it is. It's a respiratory acid. Now, normal PCO₂ level is between 35 and 45. Now, if I start to accumulate more of this respiratory acid, my number is going to go up, and I will develop respiratory acidosis. If my level of PCO₂ in the body is normal, it'll fit between 35 and 45. However, if that number drops below that, below 35, I will develop a respiratory alkalosis. So first, what is it? It's a respiratory acid. If you have too much, respiratory acidosis. Normal, fine. Too little, respiratory alkalosis. Now, how does the body control your PCO₂ level? Ventilation, blowing it off. Think about it. Oxygen comes into the cell. The cell uses the oxygen, and the byproduct, the waste, the exhaust, is the PCO₂. So during ventilation, you're blowing off that exhaust. If you're breathing normally, your PCO₂ is going to be fine.
I'm fine.
If you're not breathing enough, this exhaust is going to start to build up, your numbers are going to go up, and you'll develop respiratory acidosis. If you're breathing too fast, you're exhausting, you're blowing off, you're ventilating all this PCO₂, your level will drop in the body, it swings the other way, and you have a respiratory alkalosis. That's the PCO₂. Next, bicarb. What is it? It's a metabolic base. That's what it is. Metabolic base. An alkali, an antacid, the opposite of acidosis. It's a metabolic base. Normal levels, 22 to 26. So, if I have an increase in this metabolic base, my bicarb is going up, I will have a metabolic alkalosis. If my bicarb level drops below 22, it's a metabolic base, I don't have enough, I swing the other way and you develop a metabolic acidosis. Next, let's talk about interpreting the ABG. What are the steps we're going to take to read this blood gas? Always start with the pH. So I got my blood gas here, and I'm looking at my pH. A normal pH is 7.35 to 7.45. A perfect pH would be 7.40. If it's not 7.40, is it leaning more toward acid or more toward alkalosis? That's step one. So I got my blood gas here. My pH is 7.3. Holy smokes. The pH can only fall into a vat of acid. My numbers have fallen, so my pH reflects an overall acidosis. And I gotta go find the acidosis by looking at my PCO₂ and my bicarb and see if either of those reflect an acidosis. I always start with my PCO₂. I look at that, and in this case, my PCO₂ is 30. Now, PCO₂ is a respiratory acid. I have less than my normal level, between 35 and 45, so this reflects a respiratory alkalosis. Oh my gosh, I have an acidotic pH but a respiratory alkalosis. Still haven't found my acidosis. Let's continue on. I look at my bicarb, and my bicarb here is 20. Well, we know that bicarb is a metabolic base, but I have less than my metabolic base normal level, between 22 and 26. I have 20. That reflects a metabolic acidosis. There's my acidosis. And now we get into what's called compensation. I have a metabolic acidosis. The respiratory component is now going to compensate for that acidosis by creating a respiratory alkalosis. It's trying to blow off that acid and correct the pH. However, in this case, it didn't correct the pH. My pH is still 7.3, an overall acidosis. If the compensation had been sufficient to return my pH to a normal level, we would call that a full compensation. One side's compensating for the other. If it brings the pH back into a normal range, that's fully compensated. However, in this case, we have compensation that did not return the pH to a normal level, and we would call that a partial compensation. So, always start with your pH. If it's not perfect, is it leaning more acid or alkalosis? Whichever one that is, go find that on the PCO₂ or the bicarb. Those are the steps for reading an ABG. Now, can you have a mixed blood gas? And what that means is you have both a metabolic and a respiratory acidosis, or a metabolic and a respiratory alkalosis? Absolutely, man. This is America. Anything can happen. These particular patients are very sick and require immediate expert consult. So remember, compensation means that either the respiratory or the metabolic component has moved outside of its normal range in the opposite direction to compensate for the other side. So let's say you have a pH, an overall pH that reflects an acidosis. You look at the PCO₂, it's normal. Respiratory component's normal. The metabolic, the bicarb, reflects a metabolic acidosis. However, the respiratory, the PCO₂, was normal, within its normal range. It did not compensate. If it had compensated, it would have moved to a respiratory alkalosis. Now, if that compensation did not return the pH to its normal level, its normal parameters, we call it a partial compensation. If the compensation does return the pH within a normal range, that's fully compensated. So you can either have no compensation, partial compensation, or full compensation. But remember, we don't treat the numbers on an ABG. We treat the patient that has the numbers on the ABG. We use the numbers to help us treat the patient. I'm Mark, thanks for watching. I'll see you in the next video.